Good morning or good afternoon. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thank you for joining us today for our 9th webinar of the Winter SRS webinar series. Held every Thursday between now and May 13, this new series does include 12 talks over 12 weeks. If you haven't already, I encourage everyone to visit the srswebinars.com website to review not only the upcoming presentations, but also register to view recordings of prior webinars as well. And one item of business before we get started, if you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found in the Zoom console. Time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler, over to you.
Thank you, Mark, and welcome to all our listeners here. I'm delighted to present the speaker for this webinar. Is Matthias Radatz. Matthias is a Berliner by birth, and I would love to hear some of his historical perspective. Must have lived through an interesting time in life and history. Regardless, he's been extensively trained in neurosurgery throughout Germany and then through even more of his life in the UK. He has been involved in the Sheffield Gamma Knife, which is, I believe, the second Gamma Knife in the world after the Kerr, which I once worked on, and has a storied history there in treating a range of different pathologies, but especially in the area of AVMs. We've all learned a lot through the years from the Sheffield, England experience, and much of that experience was contributed to by Matthias Radatz. So Matthias has treated, I understand, more than 4,000 patients with the Gamma Knife and I think other radiosurgical systems. And I'm delighted that he's going to share his experience today treating AVMs. Very few people have more experience than he does. So Matthias, tell us what we've learned about treating thousands of AVM patients over 33 years.
Thank you very much, John. I'm just trying now to share my screen. There we are. So I hope that that is all in order now. Thank you very much, John, for that introduction. Thank you very much for Zap Surgical for the invitation to give my talk on our experience of 36 years now on treating stereotactic radiosurgical AVMs in Sheffield. I have no conflicts to declare. We are utilizing a Gamma Knife. Here you see here in this picture the prototype of the Gamma Knife invented by Professor Leksell, who wanted to treat patients minimally invasively in Sweden, and developed as part of his interest as a functional neurosurgeon a radiation tool coined the name Gamma Knife to deliver high dose radiation to a very targeted, focused, small volume. Capable of lesioning the brain and structures within the brain he wanted to treat. So the Gamma Knife is, in that sense, a surgical tool developed by a neurosurgeon for neurosurgical procedures, delivering sub-millimeter accurate high-dose radiation to in a minimal invasive fashion. It allows treatment of otherwise inoperable lesion with very low complication rates. It utilizes cobalt-60 sources. They are of a small, able to treat very small lesions. Typically, we deliver 25 gray to the prescription isodose line in a single fraction. In some patients, we do multiple fractions treatments, but that is typically not in AVMs, apart from stage treatments, which we come later into. The reason why we treat AVMs started in 1970s. Ladislav Steiner, working with Leksell, published the first case report where he successfully obliterated an arteriovenous malformation. And 2 years later, he published a milestone paper where he could show that irradiating the whole AVM nidus was leading to obliteration of those AVMs. What he could as well establish was that it was not good enough to irradiate the feeding arteries or part of the nidus. And then David Forster, who was a scholar with Lars Leksell in those days, published in 1979 on the meeting in Plymouth of the British Neurosurgical Society, his first experience in Sweden with radiosurgery for arteriovenous malformations. That paper was received with very great interest. It showed that after 1 year, nearly 40% of those treated AVMs were obliterated. And after 2 years, that went up to 85% nearly, with only a failure rate with no response in only 5% of patients. What could be shown is that the radiation effect led to a myofibroblast immigration in these abnormal vessel structures in the AVM nidus and collagen deposition, leading to occlusion of these vessels and cure of the AVM. This picture shows David Forster with the first Gamma Knife outside Sweden. Well, it was a second. The first went to Buenos Aires because the Sheffield bunker wasn't ready. We got the machine without an automatic positioning system, which was a blessing as that had lots of problems. That is the 1985 machine. So what does stereotactic radiosurgery involve? First, stereotactic imaging. To define the stereotactic space and to set the target contours. Then the dose planning, precise conformation to the contour, avoidance of eloquent structures, which one can facilitate with a gamma knife very nicely because of the ability to block collimators. And then the dose delivery to the target in sub-millimeter fashion, very reliable machine as you have very little few moving parts, and a very reliable source, the age of which allows dose calculation very precisely. AVM planning is typically done on imaging facilities utilizing DSA, digital subtraction angiography, and MRI. In some patients who are not suitable for an MRI due to contraindications, we use CTA. Dose planning, here just a small example of the dose plan. You can see the yellow line is a prescription isodose line outlining the nidus. The 20 and 10% isodose lines shown here, where minor irradiation still goes into the penumbra of the brain, usually not causing a deficit. And then the dose delivery is carried out by just placing the patient in the gamma knife, setting the targets and delivering that radiation, pending on how large a lesion is, how complex it is, how many isodose centers you're placing. The delivery time takes lesser or longer time. This is a up-to-date Leksell gamma knife model. It is a perfection, the newest of the machines without a cone beam CT on it. The cone beam CT model, which we have in Sheffield as well, is called the Icon. And then you have different other radiosurgical tools. You can see here Zap Surgical, and then you have the Cyber Knife, you have other LINAC accelerators from Varian and from BrainLab, which with their different collimator systems, single collimators, multi-leaf collimators to facilitate radiosurgical treatment. Important that only because you have a fancy tool doesn't mean that you are up to deliver first-class treatment. So there are two quotes from Lars Leksell, which I think fit extremely well into neurosurgical, radiosurgical training and treatment. A tool is no better than the hand that holds the tool, and a fool with a tool is still a fool. When we're looking at the Sheffield experience, you can see in 1985 we started. This was due to the fact that the Society of British Neurosurgeons agreed to fund with the government a research facility as a national center for the treatment of arteriovenous malformations on the grounds of the excellent results achieved in Stockholm in AVM treatments. And so you can see that the red bars are AVM treatments annually over those last 30 plus years in Sheffield. We are now nearly at 8,000. We are treating about 44% of the incidence of AVMs in the UK. Originally, in the early days, we would have many international treatments as well. But very original, these were the selected patients to establish that the early series from Stockholm was reproducible and that was really the way to go. Important, it's a multimodality treatment. AVMs include 3 subspecialties: microsurgical neurosurgeons, so for invasive surgery, endovascular radiologists, or in the States, neurosurgeons, and radiosurgeons. And it's very rare that you have somebody who is doing all 3 of it. I haven't met one who is doing that. Nevertheless, multimodality treatment is often the choice for patients with complex AVMs who have intranidal fistulae or feeding artery aneurysms, and complex AVMs which might benefit from the management with utilizing more than one modality. There are some patients who will never be suitable for any treatment currently, and they will be just observed. So most important, the collaborative management and decision-making. What drives the decision-making really is the urgency of treatment required, the expected success rate, and the expected risk. And that facilitates really the first choice decision how to proceed in the given patient. We know that we are very successful with Spätzler-Martin grade 1 and 2 AVMs. We cure 80 to 90, high 90% percentages of patients in those patient groups. We are lesser successful in the higher grade Spätzler-Martin groups of 4 and 5. The same accounts, and it's transferable really to the overall maximum diameter of lesions and their volume. So we are very successful under 3 centimeter diameter, lesser successful 3 to 6, and then the success rate goes down when a lesion becomes really very formidable. When we had treated nearly just over 5,500 patients, we took stock, and we noticed that we had treated over 1,400 lesions with over 3 centimeter diameter. So a group of patients we would class harboring large arteriovenous malformations. And we went into this group and established what we had actually achieved over that evolutionary period of 15, 20, probably 20 years of radiosurgery in Sheffield. And you can see that indeed it is a formidable group with nearly 50% of Spätzler-Martin grade 4 and 5s included in that group. Presenting symptoms in many patients: hemorrhage 28%, seizures 48%, and the vascular steel in 14%. And it doesn't come as a surprise that the pre-treatment morbidity was highest in the hemorrhage group and the steel group, whilst the epilepsy group typically did have very little pre-treatment morbidity. What we found in those groups is that the hemispheric AVMs, which had not bled before, had a low risk of bleeding, under 1% actually, while the deep eloquent lesions had a much higher risk of first hemorrhage, about 7%. And once they bled, both groups, risk of further hemorrhage materially increased to 6.6 and 16.4% respectively for the deep eloquent lesions. So we looked at that historic group in the historic setting, and we called those groups, the first one non-conformal in the 1980s, conformal in the 90s, and then from 2000 to 2008, an MRI and angio group with more sophisticated plannings available. So this is just an example of the non-conformal group. You can see a very basic plan, 2 radiation isodose centers, and coverage is poor in that group. Conformal angio planning, better isodose planning, more field, more isodose centers used, more computer sophistication in form of a planning software allowing a more elaborate plan to similar volumes with better coverage. And then the more sophisticated group allowing 3-dimensional evaluation of the nidus, cutting out and reducing draining veins to the maximum and really focusing down on the nidus with increased isocenter use, still to the similar volume, but in general, still with coverage up to only 94%. What we could show that obliteration rate increased over the historic period. So the more sophisticated the planning became, the more success rate we had in obliterating in these large lesions. Nevertheless, it never went over 50% occlusion rate in a time frame of up to 4 years. Complication rates were in the original group about 20% that got better with the sophistication of the treatment, but it remained at about 15%. And the overall outcome of the treatment improved. We obliterated more lesions with more sophistication of the treatment, but again, it didn't get over 50%. Well, we questioned why did we have so many unchanged lesions after high-dose radiation delivery. The unchanged is not so much a problem because that group is a group where we do not affect the nidus, but we cause no neurological new deficit. So these patients had not been harmed. What we were looking into is why, what would this be the case? Why do not more patients respond? And what we looked at was the rate of embolizations, and that was increasing over the years with sophistication of gamma knife treatment, sophistication of endovascular treatment improved. So we had 44% of our large AVMs were actually pre-embolized. And then we looked at the outcome of that group versus the non-embolized group. And in the most sophisticated treatment planning group, we could show that without embolization, our success rate was actually materially higher. It went up to 60%, whilst with embolization, that obliteration rate was under 40%. So in summary, single fraction radiosurgery with modern planning achieves 50% obliteration. Without embolization, 60%. Side effects remain about 15%. And overall, we had a mortality of about around 5% in those patients. It's not clear if that is due to the delay of the radiation effect and hemorrhage occurring in that delay period, or if we would have potentially have provoked such a hemorrhage with radiation treatment. We prefer de novo stereotactic radiosurgery because we feel that the embolization reduces the chance of cure. And because of the persistent high side effects, we started at that time to consider volume staged radiosurgical treatment. Now, just talking about embolization, what would we like from embolization? We would like a segmental embolization with a lasting effect, self-embolization, and leaving us for radiosurgical management a circumscribed small remnant. What we often see is patchy, fragmented embolization. We see often recanalization. We get attenuation and distortion from the embolizing material, which makes the axial interpretation of imaging more difficult. The effect of the embolic material is not quite clear. There is a suggestion that it might be angiogenetic, causing angiogenetic activity and neovascularization. And in that context, radiosurgery, unfortunately, often has received referrals because of failed embolizations, and we need to end up picking up the pieces. So what we get rarely is a very nicely embolized compact remnant. So this is a beautiful embolization, a very large cast with a small target with a very well targetable lesion. Even with a good embolization, we see that when we do contrast MRI enhanced scans, that within the embolizing cast, you still can have shunting AVM nidus. So the embolizing cast on the angiogram can be very misleading. We often get patchy embolization where we end up to treat still the whole nidus in any event. And that is very sad, because at the end of the day, those patients may have had 3, 4, 5 embolizations to achieve basically nothing, and is posing them to a lot of radiation exposure and the potential side effects of each single embolization treatment. We get failed embolizations where you see a lot of embolizing material, but the nidus remains the same size, and we treat ending up treating the whole nidus in any event. We see failed embolization with very little effect and very little embolizing material being placed. And then we have very occasional patients who undergo a ridiculous number of embolizations without any effect. The gentleman was completely bald from the exposure of the radiation and angio imaging during those procedures. We see recanalization. So AVM nidus, good embolization here. We picked up this bit, treated it, it obliterated, but then later on, we see the recanalization of the previously embolized part of the AVM. We see recanalization here, beautifully treated, completely embolized. There was no remnant. And then when it comes to radiosurgery, there is a large recurrence. And then we see lesions which are actually primarily beautifully compact and very suitable for radiosurgery to be turned with embolization into a mess. With diffuse nidus, where we have to irradiate at the end of the day a larger area than we normally would have done. So onyx before SRS is that added trouble. We get, there is a possibility that it reduces the radiation delivery due to a beam attenuation. We get the image distortion, which makes it more difficult to plan this sophisticatedly. And then we get the query vasoproliferation with onyx, which may be one of the reasons why the failure rate is higher. Now, the stage treatments, we have a large number of those. They are published now as well. And you can see again, that this is a formidable group with 46% of Spätzler-Martin grade 4 and 5s. We have matched them against a single stage experience, and you can see 81 2-stage treatments, 3-stage treatments in 3 patients. The group, 21% deep eloquent lesions, 78 hemispheric, and hemorrhage in 44%. We stage in a way that we can utilize either the vascular supply, in this case here the carotid and vertebral territory, or we can arbitrarily split the treatment for the nidus. That depends on the day and on the angio architecture of that AVM. What we could show is comparing it with the single staged group that we achieve the same obliteration rate with a staged volume stage treatment. But what is most important is we more than halve the permanent radiation-induced side effects from 15% to 16.5%, which is excellent news for those patients. Just a couple of examples of cure of large staged treatments here, large hemispheric AVM, which you can see is after 4 years completely obliterated. Here the axial MRI imaging. just showing that part where the nidus was present before. Another example, 36-year-old gentleman presented with hemorrhage, 36 months later, after a 2-stage treatment, completely obliterated. The nidus is completely gone, no early draining vein remaining. We achieve cure with different modalities. This is a stage treatment for a large hemispheric AVM, which was then a small remnant surgically resected. Summary of large AVMs. Volume stage radiosurgery reduces permanent side effects to 6.5%. Pre-embolization reduces chances of total obliteration and adds the risk. The residuum, one should consider all options, and that should be multidisciplinary discussed. Disabling morbidity is rare. Post-radiation effects, we do see them typically 3 to 6 months later. Radiation effects, here radiation edema, typically settles down with short courses of steroids. Here another radiation effect are often seen in patients who respond very quickly. And this is a very rare complication. It's cyst formation after multiple radiation treatments, probably 10, 15, 20 years after radiation dose has been delivered. And then the rare complication of radiation necrosis, like in this picture. Role of embolization is generally found to be negative in our view. We avoid embolization and treat primarily with staged radiosurgery. Embolization is reserved to target potential bleeding source, not to volume reduce. The use of endovascular treatment, we would typically advise to treat feeding artery aneurysms, which has been successfully done here. And then when you have direct fistulas after radiation treatment, a direct fistula remained here, which was curatively treated with embolization thereafter. And this lesion did not respond to radiosurgery at all after 2.5, 3 years, and was successfully completely coiled with just a couple of coils in here. So is radiosurgery suitable for all brain AVMs? Technically not for all, but for most. A few exceptions, fistulas and diffuse nidi, large brainstem AVMs. It is advised to involve experts of all 3 treatment modalities. There's time to design management of unruptured AVMs. And once a patient with a ruptured AVM is clinically stable, early treatment is advocated. Now, what's operable and treatable in my hands? We all think we are lions, but there are lesions which we can't treat. And one just needs to accept that one shouldn't start treating an AVM if one cannot envisage a cure at the end of the day. So thank you very much for listening. Thank you very much for giving me this opportunity. And thank you very much to the team in Sheffield, without which that work would have not been possible.
John, it looks like you're on mute. Can you? While John is trying to find his unmute button, I do have a question here. Would you comment on radionecrosis rate on large versus small AVMs? Are they similar?
No, they're not similar. The radiation necrosis rate is higher in patients who have large lesions which require often a second, or in some patients even a third treatment. So we do very, very rarely see radiation necrosis with a primary treatment.
So Matthias, John Adler, sorry, my internet dropped for a second. When it comes to necrosis, have you tried, has Avastin been much of an improvement over the prior treatments?
Okay, Avastin is very expensive and is not licensed for this purpose in the UK. But yeah, if one goes by published reports, then it is obviously, it is very effective in reducing the edema. Yeah, if you fail to control the edema with steroids, then Avastin, as long as it is licensed in your country, would be useful to use.
That's unfortunate that it's not licensed, because in my experience, it can make a big difference. And I personally had a patient who had relatively mild radiation necrosis. I put him on steroids and he developed an aspergillosis brain infection and died. And it's tragic that steroids just led to that kind of immunosuppression. So another question about radiation necrosis. So do you think radiation necrosis incidence is influenced by staged AVM? And are you, obviously the intent of staged AVM treatments is to minimize radiation necrosis, and are we achieving that objective?
The primary staged radiation treatments very rarely have a radiation necrosis. I think we achieve that. Now, when you look at the primary treatment of a staged AVM treatment, the cure rate is about 60% in our hands. So 60% with primary treatment, but many patients of those 40% who have not been cured after that primary volume stage treatment have responded very well and have, instead of a very large AVM, now a very small AVM or just a persistent shunt. And those patients are considered for further radiation treatment. And in that group, you have a higher risk of radiation necrosis because they get an add-on dose of a second treatment into a pre-irradiated part of the brain tissue.
So how long do you wait if you still see persistent shunt or persistent AVM after radiosurgery? How long do you wait before retreating?
Okay. We know that from our data over the last 36 years, we know that when you follow those patients up after 4 years, and you have a DSA and there's a persistent nidus in shunt, this will not go after that treatment 4 years ago. So we see still changes to nidi occurring after 3 years, but after 4 years not. So in somebody who had volume staged radiosurgery before, we would not reconsider to treat them again before 4 years have passed, because we want to wait until this nidus has shrunk as much as possible and the volume for that further seance of radiosurgery is as little as possible to minimize the risk of radiation necrosis.
Perfect. So the short answer will be 4 years. Good number to keep in mind.
Yeah.
So another question is, ask a question about when to fractionate. Now, I don't know if this is volume fractionation or staging, but I guess the question is relating to fractionation, the entire AVM. So, okay, there's the question. Now, the comment on the effectiveness of fractionation versus volume stage treatment.
Well, the success of fractionation of an AVM is very poor. So the same counts for if you use doses below 17 gray, the obliteration rate drops down very, very materially. So we would not consider giving smaller doses than 17.5 gray, even in a volume staged fashion. And we wouldn't fractionate an AVM.
Gotcha. This is a question I'm interested in as well, and I think Sheffield has the best data in the world. It says, any problems with cancers induced by radiosurgery treatment?
Okay. Yeah, I love that question because that's always the argument, and it was always the argument when we started in the early days treating acoustic neuromas. Oh, you turn them malignant, and patients were scaremongered and told, oh, they turn it malignant and you get cancer. Well, we matched our patients, 150,000 patient years against the UK cancer registry, and we could not show an elevation of any cancer diagnosis in that cohort of patients, which is the largest published series. And I presented it in Brazil.
And in fact, if I recall, there was even slightly lower incidence of cancer, at least in the past.
But that was one of the factors. That's obviously a statistical issue, how it falls on the. But my colleague who presented it at the first series of that at the time, it was noted that skin cancers were a little bit reduced after in the group of patients who had radiosurgery.
Well, it is paradoxical, but there is the theory of hormesis that implies a little bit of radiation is actually stimulates the immune system in a way that protects against cancer. So to what extent are we protecting? So, I mean, you've been pretty emphatic here that you don't embark on a treatment unless you're convinced that you can get a complete obliteration. But to what extent are patients being protected short of a complete obliteration? I don't think from your lecture so far, understand exactly to what extent you might think there's a protective effect.
Okay, the protective effect is there when you're cured. If you're not cured, I don't think I would argue that there's a protective effect, because you still have in our experience, the persistent annual hemorrhage risk. In the very large volume staged AVMs, the risk of statistical risk of suffering a brain hemorrhage increases by about 1 to 2% in the first and second year after volume staged radiosurgical management. It goes then back to the pre-volume stage treatment level and only reduces to 0 once the lesion is completely gone. So at the end of the day, if you have an abnormal shunt and you're not falling into what we call the group 3 and group 4 without early venous drainage, then you have a persistent hemorrhage risk, and in our eyes, you're not protected.
And do surgeons, is that the time to reconsider microsurgery?
I think you can. If you have a remnant, you should go back and to the drawing board and consider all options. So if you have a lesion then which is suddenly becoming amenable for microsurgical resection, yes, of course, that is an option. If it is amenable for embolization, yes, of course, it is an option. And if it is suitable or felt most suitable for second radiosurgical management, then we are happy to consider that. In particular, in the peritectal AVMs, we are very happy to give a second and even a third dose, because we know that we cause very little side effects in those lesions anatomically placed in the peritectal lesion. And they tolerate that treatment very well, the second and the third, without additional side effects, and they do obliterate in 2/3 of patients.
So, I mean, I too have experienced in my career a lot of difficulties from neurointerventionalists fragmenting a contiguous AVM into something that's becomes very difficult to treat with radiosurgery. So have you had success educating neurointerventionalists, convincing them to stay their hand? Or is the temptation just so great that they feel such a sense of satisfaction with a little onyx here and a little onyx there that they still insist on fragmenting AVMs? I hope my question makes sense, and just interested in your philosophical perspective.
Yeah, I think you're hitting the nail on the head. The problem really is that even in the very established endovascular centers, there are not very good published series, and any publications, usually anecdotal reports. The groups presented internationally typically are very heterogeneous, and it's very difficult to get a handle on what actually is a good endovascular target. I think if you have endovascular treatment for an AVM and it is felt by the MDT that is a good way forward, if failed microsurgical resection, then that should be set up in such a way that the patient is embolized, partially embolized, and goes to theater thereafter as quickly as possible, probably best on the same day, because if you partially embolize an AVM, there's evidence that you massively increase the hemorrhage risk in the acute phase. So I think it's difficult to stop this dropping a little bit of an onyx here and onyx there when you don't have radiosurgical facilities in every unit. And you're dealing with alpha males or alpha females. They all,
I love it, love it.
They all see that they can do it. And at the end of the day, the best center in the world would have an alpha of every subspecialty. So alpha endo, alpha micro, and alpha radio. But those centers don't exist really, because all these alphas compete with each other, and one of them wants to be the super alpha. And that actually prevents, I think, what could be the optimal multidisciplinary approach to the problem in hand.
Or maybe someone should be dually trained in all these procedures. I mean, to some extent, I don't think someone should be embolizing an AVM without consulting a radiosurgeon, someone who's radiosurgical experience beforehand.
I agree.
It's one thing to make a diagnosis, but the minute you're just going to embark on a therapy, make sure you don't make the situation worse, because in my experience, neurointerventionalists have probably hurt more patients at the end of this path than they've helped.
Yeah, I agree. I totally agree. And that's what we say to our referrers. Do not embolize or attempt a partial resection until you have discussed this with a radiosurgeon or in a full MDT, where a radiosurgeon participates, so that you don't unnecessarily create a second procedure with all its side effects and potential complications associated when one management option could have dealt with the problem in hand.
Spoken like an alpha radiosurgeon. I like it. So I'm going to ask one last question. What's next? What can we do better? Give me a frontier story. What will radiosurgery for AVMs look like over the next 1 or 2 decades?
Well, that's an interesting one. I think I remember David Forster talking about radiosensitizers, and I can see only that side effects will further reduce if one can manage to sensitize the pathological vessels to respond more effectively to a lower dose. Otherwise, I can't see that we are going to go in leaps forward here. Alternatively, what might be a possibility is that one portions these AVMs in so many parts that instead of having 3 volume stages, that you have 4 or 5 with a mask-based rather than frame-based. But again, that's experimental, and nowadays this is very difficult, because this needs to be done through trials, and to organize a trial with that, to have enrollment, and you need a multi-center involvement, and I think it will be very difficult.
Well, no one has taught us more about the treatment of AVMs with radiosurgery than you and the Sheffield group. So we compliment you, we salute you, and encourage you to keep up your good work, and appreciate you sharing what you've learned over the years with all of us this morning, this evening, wherever you are in the world today. So I thank you, Matthias, and I thank everyone for joining us this morning, and I look forward to catching up again next week. Thank you, Matthias.
Thank you very much for having me. Thank you.
My pleasure. Our pleasure. All the best. Bye-bye now.
Bye-bye.